We have a great program here for you tonight. We have two presenters for managing your running injuries as you prepare for the marathon. The first one is the infamous Dr. Dennis Cardone. So I'm just going to give you a little brief intro. So he is a fellowship trained and board certified specialist in pediatric and adult sports medicine and a clinical associate professor at the NYU Hospital for Joint Diseases in the Department of Orthopedic Surgery. He received his medical degree at New York College of Osteopathic Medicine and completed residency and fellowship at UMD-NJ. After UMD-NJ, Dr. Cardone went to serve as both Director of Sports Medicine and Director of the Sports Medicine Fellowship Program. In addition to lecturing nationally on sports medicine topics, Dr. Cardone has published numerous articles in peer-reviewed journals and textbooks. He has been a team physician for NYU Athletics, Princeton University, Rutgers University, numerous high schools, and the Paralympics. Dr. Cardone also serves on the medical team for the New York City Marathon as well as the US Open and is co-director of the Partners in Youth program and has served on numerous sports medicine advisory panels. He's the co-host of Sirius XM Sports Medicine Radio, and he has a very special interest in treating young athletes and athletes with special needs, and his practice is open to people of all ages. So let's welcome Dr. Cardone.
Thank you, Laura. Well, thank you and welcome. Any runners? Or is everybody training for the marathon, or who's not training for the marathon? Is there someone? Okay, oh, very good, very good. Okay, so I don't know if we were going to talk about these 7 running injuries, the big 7, but it's grown. It's now the top 15. So they're not all about injuries, but it's just maybe hopefully some like hints or things that we could talk about that afflict runners and some recommendations for runners. And I always like it when it's informal, so please, if I say something that doesn't make sense or if a question pops up in your head, please feel free to make a comment or raise your hand or ask a question. I mean, at the end there'll be a more formal Q&A session, but please feel free to make this as informal as possible. So, there is evidence that running is one of the most efficient ways to achieve fitness and promote long-term exercise. So we all know it's a great form of exercise and a great way to get exercise, right? I mean, no matter where you are, if you're traveling, it's just a great way to throw on a pair of sneakers and go out there and run. And it's nice, you don't even need to call anybody up. You could just go out and do it on your own. But the one negative that we all know about running is that there certainly is a significantly high rate of injury. And when you look at all the studies and evidence over the years in runners, about 50% of runners are injured yearly, have some type of injury, whether it's an acute injury, but more common it is an overuse type injury that a runner will have. And at any one point, upwards of 25% of runners are nursing some type of injury. So those are pretty high numbers for injury. So it'd be nice if we certainly had a way, number one, to try to prevent these injuries, and number 2, certainly how to treat these efficiently to keep runners running and keep them on the road. Okay, the top 15. So the top 15 when we talk about like recommendations and things for runners. So number 1, when you look at, so we're talking about running prevention right now. So running greater than 40 miles per week is associated with significant risk of injury. So certainly runners, every time they make a jump in their running schedule, when they go from 20 to 30 miles, 30 to 40 miles, over 40 miles, they're significantly increasing their risk for injury. But again, when you look at, so a lot of what we're going to talk about truly is looking at the evidence in runners and looking at the studies that have been done over the years. So the big magical number is certainly 40. So for some reason, all the studies will tell us that once you go over 40 miles per week, you have a significant increase in risk of injury. So everything in medicine and a lot in life is about risk and benefit, right? So the real question is, once you start getting 40 miles and above, is the benefit that you get from running truly worth the risk? And I think there's a lot of question about that, and we'll talk more about that. But a good example would be, say, like our NYU runners on the cross-country team. I mean, they are putting in every season, both the boys and girls team, they put in 70 plus miles a week on the hard concrete of New York City streets. So you can imagine these 18 and 22-year-olds, they are breaking down, absolutely. So everybody hits some point where everyone, no matter how elite they are and how good their training is, once they start bumping up their mileage, they are typically going to have a significant injury. Do you know who that is a picture of? Who is it? The point here is that here's an elite runner, a female elite runner, and every year for New York City has come over the past 3 to 4 years nursing some type of stress fracture. So again, once you're at some type of mileage, it doesn't matter whether you're just your recreational runner or an elite runner. Once you hit a certain point, male, female, it doesn't matter, the body's going to break down, there's an increased risk for injury. So here was a nice study, and it's dated, it's 1989, but it was an excellent study from the International Journal of Sports Medicine. They looked at 115 runners, and they followed them over an 18 to 20-month period. 85% of them experienced at least one injury, where they missed at least one day of training. And they looked at their injuries, but most important, what they were looking at was trying to find which risk factors or which factors made a difference in increasing their risk for injury. And the number one risk factor that they found was exactly that. Once they got over 40 miles per week, that was the strongest factor or predictor for injury. Other factors, previous injury in the past 12 months, so if they were nursing some other type of injury, so potentially they never fully recovered from that previous type injury. If they do daily running, so that runner who's truly running 5, 6, 7 days per week also increases their risk for injury. And when you look at a lot of these training programs, right, that people follow for, say, the New York City Marathon or for any, say, endurance run, many of them do have the athletes running 5+ days per week. So what's best always, again, even for an elite level runner, would be to run only 3 to 4 days per week and mix in cross-training type days. So run Monday, cross-train Tuesday, run Wednesday, cross-train Thursday. And the length of a long run was also a risk factor. So meaning if you did one long run, say over 15 miles, over 20 miles, over 25 miles, this was also a risk factor. And that's also a problem when you look at a lot of the regimens that people follow in preparing for the New York City Marathon, right? How often do you hear about the runner, I have to do my 22-mile run this weekend, that's on my schedule. I have to do my 18-mile run. And for several weeks leading up to the marathon, they're doing these many multiple runs. And you know what? And these are the runners that are not making it to the starting line, right? They're not making it to even start the marathon. They're breaking down, getting injured even before the marathon. So total mileage, and a big number, is at 40 miles per week. Number 2, and I won't go into this because the second speaker will touch upon this much more, but hip muscle weakness increases the overall injury risk of the lower extremities. So here are multiple studies that have been done in good orthopedic sports journals saying that hip abductor, right? So the hip abductors are the muscles and tendons that allow the hip to come out, the ones that start on the side of the hip and go down the side of the leg to the knee. So hip abductor and hip flexor, so flexor is the one that bend the legs up, moving it up, moving the hip up, moving the knee up. So these are weakness in the abductors and flexors have absolutely been shown to be a factor in specific type injuries. And these are 2 of the big 7, right? These are 2 big overuse injuries for runners, iliotibial band syndrome and patellofemoral syndrome, which we will talk about. So hip flexors and hip abductors, weakness, risk for injury. Number 3, during the race, do not drink at every fluid stop. So when you talk about fluids and you talk about hydration, it's really come full circle, right? So if you knew anybody who was running the New York City Marathon in the 1970s, they would tell you that at that time, when they first started running the New York City Marathon, it was not a 5-borough marathon, it was just around Central Park multiple times. The thought was no fluid intake, 0. They pretty much did not take in any fluids whatsoever. And then sometime, especially around in the 90s and in the early 2000s, it went exactly opposite, right? It was now there were multiple drink stations, multiple water stations especially, and the thought was during the marathon you should be stopping at every one of these water stations to hydrate. And you want to remain well hydrated, will improve performance and decrease risk for certain injuries, including, say, heat illness. But what started to happen is, especially in a certain population, ones who are running endurance races, more females than males, and more typically the slower runners, right? So the ones who are out on the course for 6+ hours, the ones who are really stopping at every single water station, And those who are drinking all water rather than sports drinks containing some type of sodium supplement, these are the ones who started noticing a problem. And the major problem was something known as hyponatremia, where their sodium levels would start to fall while running. And if the sodium falls to a significant level because of this overhydration, then the result can be catastrophic. So there have been runners, again, typically this type population, who have died because of this hyponatremia. So because of this, and because of the knowledge that we've gained over the past, be it several years, decade, it's kind of come full circle a little bit again. So the general recommendation now has gone back to don't stop at every water station. Don't feel like you have to overhydrate, but it is okay to only drink when you're thirsty. So the rule before was, by the time you're thirsty, it's already too late, you're behind. But it's come again full circle to say you can wait till you're thirsty. So yes, there is some proper hydration prior to the race. You should be well hydrated. But during the race, it is okay to wait until you're thirsty to continue your hydration. And your hydration, right, once you're doing any activity, any event for over 60 minutes, it should be supplemented with something other than just water. So probably, reach for some type of sports drink as well. So yes, you could have water, but when you're out there for more than 60 minutes, whatever activity you're doing, it should be supplemented with some type of sports drink. Number 4. So this is the biggie, right? This is the big one in vogue, barefoot running, right? Or somewhere in between. So it's really, the big thing is, barefoot or minimalist type shoes. So what's the thought? The thought is when you look at all the running shoes that have been through the past decades, the heel of the shoe is getting built up more and more and more. So the thought is that people are becoming more and more heel strikers. So heel striking potentially leads to the increased risk of some of these overuse injuries. So now there's a little bit of this push, a little bit of this movement to stop people or get them away from being heel strikers and to become more midfoot strikers. So what would that do? If you're a more midfoot striker, it would shorten your stride, make it a little bit more springier, less impact. So somewhere in between these well-built, well-heeled running shoes and the minimalist shoe is probably where we all want to be, in some type of shoe, a tweener, some type of tweener shoe. But because of media and because of what we hear and some of the books that have come out, this barefoot running craze, is with us. And we see many runners in the office who have started barefoot or wearing one of the minimalist shoes, such as you see on the screen. And too often, again, they just start out doing too much too quickly. So I've had a couple of runners, they'll say to me, I put on the minimalist shoe and I did a couple of runs across, say, the Brooklyn Bridge, whatever it was, and they've coming in right now with a stress reaction, or they're coming in, a bone injury, I should say, or they're coming in with an Achilles problem or a calf problem, right? Because if you go to the minimalist shoe, suddenly you're up on your toes a little bit more, and that's a big stressor for the calf and the Achilles. So if you are going to go to a more minimalist shoe or some tweener type shoe, that break-in period is so important. Don't immediately just switch and start keeping up the same mileage you were doing in your previous shoe. You need to have a slow break-in type period. It's not for everybody, certainly, these minimalist type shoes, but it could be something to think about in your running, whether to transition to a minimalist type shoe. So I don't know if in the 1986 Olympics, I don't know if you remember, but this was Zola Budd, right? So Zola Budd was a runner from South Africa, and you can see back in 1986, way ahead of her time, although certainly there were barefoot runners in certain parts of this world that have been running for centuries, obviously, but she was a barefoot runner, and this was a big race at the Olympics, if you know the American Mary Decker. And so there was big hype about this race, but what happened is Mary Decker got tripped up and never did finish the race. But anyway, it's interesting to see Zola Budd, this barefoot runner, even at that time. So number 5, on race day, do what you have done during training, no changes. So this is big. So if you've made it to race day and you're doing pretty well and you haven't had any injuries, now is not the time to suddenly start to make some changes in whatever it is. Certainly you don't want to change your running shoes in any way. You don't want to put anything new into your running shoes, any type of insert. And in terms of how you prepare for your training for the marathon is how you really should prepare that day for the marathon or the days leading up to the New York City Marathon, meaning food, the sports drinks that you would take. Don't suddenly, if on the course, all of a sudden start doing goo or gels that you haven't done, because it could be very upsetting to your stomach. So the key is what worked for you during your training, and that's what you want to stick with during marathon day. Don't make any significant changes. Number 6, erratic training schedules increase injury rates. So here again, common sense. Sudden increase in weekly distance, change in type of training such as hill or interval training can suddenly cause injury. So the classic example is that runner who's been training in New York City and then they say, you know what, we went up to Vermont for the weekend and suddenly I did a significant amount of hill running. And suddenly they come in with knee pain or Achilles pain or some type of bone overuse injury. So whatever you've been doing, stick with it. Don't have these sudden drastic changes in your training schedule. Stretching, right? So that's been a big controversy, and over the years everyone always said stretch before running. That's so important to make sure that you stretch. But now we know that stretching prior to running and even prior to any exercise event can actually increase the risk of injury, right? So we've gotten away from stretching prior to a run. More important is a warm-up period. So prior to any run, whether it's preparing for the New York City Marathon or the day of the marathon, there should be some type of warm-up period for 5 or 10 minutes, whether it's a brisk walk or an interval between walking and a jog or even a slight run. But you want to have this warm-up period. Your stretching should be after your activity, after, say, the marathon is a good time, or after you're training for the marathon. Stretching, or at a time completely unrelated to your exercise is probably best to do your stretching. Number 8, so pronation. So that's been big, right? Everyone always says, if you have a foot that pronates, you're at significant increased risk for injury. And if you pronate, you need to go into that local running store and make sure that you tell the salesperson that you're a pronator and you need to go into some type of stability type running shoe that has some type of big arch support. But again, if you look at all the evidence and you look at the runners, the people who pronate, so pronate, what does that mean, right? It means the foot rolls inward. So when you look at your feet, many people, especially if you're a little bit knock-kneed or you're a little bit loose, your ligaments are a little bit loose, you have some laxity where, say, you could take your thumb and bring it down to your forearm, there's a good chance that you also pronate, where your feet roll in. That's pronation. But the point here is that it's actually been shown that pronation is not such a big deal as we once thought it was. In fact, it's the exact opposite. It's people who have a high arch. So people who have a very high arch tend to have a foot that is more stiff. And these are the runners and athletes who typically have more risk of injury and problem with injury. So the person who pronates, if they're going out to run, they don't necessarily need any special insert or any special running shoe. They usually will do just fine. If they start having some foot problems or foot pain, then sure, that pronation could be addressed and they could use some type of shoe with a good arch support or some off-the-shelf type of arch support. Okay, so now the big 7, the overuse type injuries. Stress fractures, right? So this is the big one. So bone is living tissue. Every day it's getting broken down and built up a bit. So the thought is where somebody is suddenly doing significant amount of impact, such as sport like running, that suddenly the bone could be broken down faster than the body could keep up with it. And that's why it's so important to gradually progress your training, your running program. So it gives the bone literally a chance to learn and to thicken And so you don't run into this problem with a stress fracture. So it's also about having that day off from running. So that's why it's such a good idea in training to run Monday, cross-train Tuesday, run Wednesday, cross-train Thursday. To have that day off in between runs significantly can help with stress fractures. The interesting thing about stress fractures is we all have our beliefs and what causes stress fractures, but again, when you look at the evidence, there's a lot we don't know about preventing stress fractures. But some of the things that we do know, some of the risk factors potentially are pes cavus foot, that high arched foot. Pronation, we just talked about, that's really not a big risk factor at all. High mileage, we talked about over 40 miles per week. A sudden increase of mileage, yes, a potential increased risk. So that person who's running maybe 5 miles 4 times a week, and suddenly the next week they decide they're going to run 10 miles 3 times a week. Risk factor for a stress fracture. Training on hard surfaces. So they've done studies and they've looked at men and women running on the concrete surface. And you know what they found? They found for men it did not increase their risk for stress fracture, but for women it did. Why? Who knows? But for women it appears to be more of a risk factor than for men. And non-menstruation in women. So women who are not menstruating, their estrogen levels are lower. Their bone density is particularly possibly not as dense, are at increased risk for stress fractures. So that woman who's not menstruating regularly, who potentially has some eating type disorder as well, she's very thin, she's doing a significant amount of running or exercise in general, a risk factor for a stress fracture. So if you look at the x-ray and you look at the arrow, that's obviously a foot, and where it's pointing is a metatarsal, that's the middle one, so the third metatarsal. And you can see how the bone is thick at the middle part of that third metatarsal. So that's what a stress fracture would look like on an x-ray. The thing about stress fractures is that when you have a stress fracture for the first 2 or 3 weeks, you can have a normal x-ray, right? So the stress fracture is so small, x-ray is not sensitive enough to pick it up. So when it's early on, like say one of us went into a doctor's office and we were 2 weeks before the marathon and there was a concern for a stress fracture, the way to tell is not with an x-ray, but it's with an MRI. It takes 3 weeks on an x-ray because by about 3 weeks, that's when you see the body healing the fracture by laying down this new bone, this new callus bone, and that's what you see on that picture on that x-ray. That's that thickened callus bone. That's a healing stress fracture, and you know once you see a picture like that, that this is typically at least 3 weeks into the injury. So to treat these, you know, it's a bone injury. It truly is a bone fracture. It means unloading the bone, protecting the bone. So most often in a runner, you can't really say, well, stop running, stop all activity. So what you like to tell them is you can still maintain your aerobic fitness. You can cross-train, you could bicycle, you could swim, maybe an elliptical trainer, but they do need to potentially stop their impact for at least a short period of time. And it depends where their stress fracture is. Where's the most common stress fracture? In the shin, right? It's in your shin bones. Tibia is number 1. What's the second most common would be metatarsals, like this one. But they can happen anywhere. They can happen in the pelvis, in the thigh bone, the femur. They can happen in the small bone in the leg, known as the fibula. They can happen in any of the ankle bones as well. So any pain that's persistent in a runner that gets worse with impact when they're landing on their leg is always a concern for a possible stress fracture. Plantar fasciitis. So that band of tissue on the bottom of the foot that goes from the heel to the base of the toes, and you can see a picture of it on that bottom right there. So this is a common injury, a common problem in runners, not usually related to any trauma or injury, but suddenly the runner just starts to complain of some pain at the heel of their foot. This is the potential result, maybe, of heel striking. Constantly pounding on that heel over time can lead to this problem. So it's not so much an inflammation and itis. More appropriate would be for this to be called like a plantar fasciosis. Really what it is if you looked at that part of the plantar fascia that's injured, you'd see these microscopic type tears and you'd see these degenerative type changes. This is a painful condition. It's usually very painful when you take that first step in the morning, when you get out of bed on it. It's usually painful when you're running on it. and it's stubborn. This can take 3 months, 6 months, 12 months to get better, even under the best of treatment. So risk factors for it, again, you see that cavus foot or that high arched foot. Pronation, we're going to say no, that's not a risk factor for it. Older age, yes. Someone who's a little bit heavier, overweight, yes. Decreased ankle dorsiflexion, so that just means the ankle is a little bit stiff. If you bring your foot up towards your shin, it's a little bit stiff doing that. So again, you can see it's a little bit about that stiffness, a stiff foot, the high arched foot, or decreased ankle dorsiflexion. Has anyone had plantar fasciitis? Does anyone still have plantar fasciitis? They are tough. So, yeah, they're tough. You know, the treatment for plantar fasciitis is kind of interesting. It's like when you see these many treatments, it means that we don't really have that good of one treatment. So it's really about, you know, it's kind of like just throwing everything at it. So you literally just throw everything at this and you just, you know, you hope that something's going to be able to heal this or get this better sooner. But it ranges from everything to activity modification, cutting back on the running, doing more cross training, stretching of that plantar fascia, what we call the heel cord. You could roll the foot on a golf ball. You could do ice massage. Have someone who has it wear gel heel cups when they're walking the streets of New York City in their shoes and sneakers. Don't put anything into the running, no gel heel cups in the running shoes, just in the walking shoes. You can do orthotics so that there's unload, so there's less impact on that heel. Night splints such as this, because when you go to sleep at nighttime, right, the foot goes into this bent position this way, almost like on point in ballet, right? So the boot, what it does is it keeps the foot at 90 degrees, so it keeps that plantar fascia on stretch. I can't even tell you how much patients love to wear this boot to bed. They love it. It is so comfortable. They enjoy it. They don't even want to stop the boot even when they get better. They love it so much. So a boot, but the boot has to be worn for like months. It's not like it happens quickly, months. What else can you do? Anti-inflammatory medications, you know what? They don't really do much except help pain. They're not effective therapeutically. Injections, yes, you can put corticosteroid there. What does the evidence say? What does the experience say? That it helps, but only in the short term. So typically after 4, 5, 6 weeks of a corticosteroid injection, symptoms recur. Platelet-rich plasma, there's not good evidence for it, but we do use it for the very resistant cases. That's where you take blood out of the arm of the athlete runner, spin it down, get a collection of the platelets, and in that platelets are the healing and growth factors. And so you take that concentration of platelets and inject that at that area of the plantar fascia where the problem is. And the theory is that it enhances the healing process. So you're enhancing it. But it's still, even if you are enhancing it, it still takes a good 4, 6 weeks after the injection. It's an expensive injection. Insurance companies typically don't cover it. So it's usually a last resort after all other conservative treatment has failed. Shockwave therapy, if you look at the literature evidence over the past 6 months to a year, just like they use shockwave therapy for kidney stones, for example, they're now using it for plantar fasciitis, and the evidence has been pretty good. So again, someone who's failing treatment for at least 6 to 12 months, something like shockwave therapy can be successful. Surgery, you have to absolutely fail treatment for a minimum of 12 months before even thinking about surgery for this problem. But it's stubborn, a tough problem to treat. Achilles tendinosis. So here's a common runner's problem, especially aggravated with running hills, uphills, running in those minimalist type shoes. But even if you do everything correct, it can still be a problem. So it's at the back of the heel where the Achilles is. Can you lower the light for a second? Is that possible just to? Anyway, while the lights are being, we got it. So what's the big thing about the Achilles? It has a terrible, terrible blood supply. So that's what makes it so difficult to treat these Achilles problems, and again, why they become so chronic, right? You need blood supply to bring nutrition to allow for healing. So the most common area in the Achilles where people get the problem is, you could see on the MRI, this actually is, you could see in the back of the heel, it's attaching to the bone on the bottom of the screen called the calcaneus off to the right. But if you look up above where the attachment is, you see how it gets thick it gets a little bit thickened, and you can see there's a little bit white within that tendon. So that's what we call the watershed area. That's where the blood supply is absolutely the worst, and that's typically where people get most of the problems related to the Achilles. And that x-ray shows the swelling. It shows that white is some fluid, inflammation, even partial tearing within that Achilles tendon. So annual incidence, up to 10% of top-level runners get Achilles tendinosis annually. The odds of developing this is 10 times greater in the runner. It's a tendinosis again, not an itis, right? So it's not inflammatory. Again, it's degenerative. There's not inflammatory cells. It's more that microscopic tearing that you see if you looked at it under a microscope, and scar tissue that forms. The risk factors, again, excessive mileage, hill running, running on the ball of the foot, pronation, we're going to count out again, and that tight heel cord. Treatment, so here it is again, activity modification. But here's the biggie. This is the big treatment that has definitely, absolutely has made a big change in how we treat Achilles tendinosis, and the response of Achilles tendinosis is with physical therapy and what's known as eccentric strengthening. I won't talk to you about it because hopefully your next speaker will talk to you a little bit about that, but that's made a huge difference. So most runners, most athletes, once they start a physical therapy program and they get into a program with eccentric strengthening, they tend to do very well. Anterior knee pain, so anterior is front, so it's just knee pain that's in the front of the knee. And there are two major problems, patellofemoral syndrome and patellar tendinosis. Patellar is the kneecap, femur is the thigh bone, so patellofemoral just means that there's irritation, inflammation between the kneecap and the femur. This is by far the most common knee problem. It's a little bit more common in women than men. And the classic symptoms are someone may get popping, cracking, grinding in the knee, discomfort around the kneecap. If they sit for long periods of time with the knee in a bent position, it gets uncomfortable for them. If they squat, kneel, lunge, it's uncomfortable. If they go downstairs, if they run downhill, now it's more a downhill problem, they get this aggravation of symptoms as well. It's usually not an injury. It's usually that slow, gradual onset of symptoms, and very common. The treatment for this, physical therapy, so you'll hear about that next as well. Iliotibial band syndrome. So this is that band that comes down from the side of the hip and attaches at the side of the knee. And this is the one where you're on the 59th Street Bridge and you're coming down the 59th Street Bridge, and then suddenly you've never had knee pain in your life, and suddenly there's this sharp stabbing pain on the side of your knee, and it brings you into that first tent after the 59th Street Bridge. That's iliotibial band syndrome, and that's the injury that many people say, I cannot run through this problem. Someone's stabbing me with a screwdriver. So hopefully that won't happen to you on the day of the marathon, but it is common at that tent. But anyway, this is the one, again, there's no trauma, there's no injury, it kind of sneaks up on you. The classic history that someone will say is, I could run for 2 miles or 3 miles, and then all of a sudden I get that pain on the side of my knee. And it's consistent. And the next day, so I took a couple of days off, and then I started to run again. And I could run for 2 or 3 miles pain-free, and then I get the pain on the side of my knee. That's classic iliotibial band syndrome. So the theory used to be that that band was getting inflamed and irritated as it passed over that bony prominence that we have on the side of our knee. So after a while, going back and forth, there'd be friction on the band. But now we know, when we look at our MRI studies and we've looked at that muscle, that tendon, that iliotibial band, it usually looks normal, even in people with iliotibial band syndrome. So it's deep to the iliotibial band. There's an area of soft tissue. There's a fluid collection, typically the bursa, and other soft tissue inflammation deep to the iliotibial band that becomes the problem. But the treatment here, for another one of these very stubborn problems, the first thing truly is physical therapy. And it's about a stretching program, yes, but just as important or more important is a strengthening program. And I'm not going to talk to you about that strengthening program or what muscles need to be strengthened, because that's coming up next as well. So physical therapy for the real resistant ones, or oftentimes runners will get this maybe even just a week or 2 before the marathon, and they come into the office and they're like, I have just trained for 8 months and I need to run in this marathon. You have to get me to that marathon. So for those, an injection could be a nice solution. A cortisone injection can sometimes be a very good solution in the short term to get at least quiet down the symptoms and get people through the race. It is a safe injection and it can make a difference, but again, the key treatment here is physical therapy. The other two in the big seven are shin splints. So it's a little bit like stress fracture, right? So your pre-stress fracture is shin splints. So that's what we call a stress reaction of the bone. So we talked about bone being living tissue, broken down and built up. So here what's happened is the bone is getting irritated. It's a pre-stress fracture. The lining of the bone gets irritated and suddenly it starts to lead to pain symptoms. Usually it's during the run, but it could also be after the run. If you feel along, what's the most common bone that gets this is the shin bone, the tibia, and it's usually on the front middle side, on the inside part of the tibia where people will typically get their shin splints. The treatment for this, sometimes all it takes is 7 days, 5 days, 10 days of stopping running and cross training, and oftentimes these shin splints can quiet down. But if you keep trying to run on shin splints, that's your risk to potentially develop or turn this into a stress fracture. So heed the warning of shin splints and cross train and take some time away from running. A hamstring strain, now if you thought some of those other injuries were stubborn and chronic, this is the granddaddy of them all. That hamstring strain that is caused by no injury or trauma, and suddenly all of a sudden the runner has pain in their butt or right at the base of their butt, and they've got what's known as a high hamstring strain, proximal hamstring strain. Hurts worse running uphill, running up steps, and sitting. So it's very, very common for people to complain, when I sit, it really hurts me in the butt. Back pain does that as well, so you need to make sure it's not back pain, but oftentimes in a runner it's this hamstring injury, and it's one of those, again, where you throw everything at it and still months can go by, you try everything, medications, injections, physical therapy, everything, and these are stubborn. Hopefully no one has a high hamstring injury. Anybody? Good. Number 14, replace your running shoes after 250 to 500 miles. So it's just a general rule. You know, too many people wait for their sneakers to wear out on the bottom, but you've already lost your cushioning, shock absorption well before that. So heed, think about your mileage. Usually for most runners, it's at least every 6 months, but it could be more frequent. Do not ignore the warning signs of an injury and continue to train with pain. This is a sure way to end up watching other people run the marathon. So we will take questions later. Thank you so much. It has been my pleasure.